based on the Q&A that happened at the end of last meeting and the table about like different frameworks that have been considered in different places. I don't think anything super controversial. It's just let's have more formal discussions about different models of safe supply and what that could look like in Washington and what are the possibilities. Yeah, happy to take any questions.
All right, questions for Adam? Kevin? Kevin? Maybe on mute.
Yeah, I am. Thank you. Hey, Adam,
No
great work on the research. You've been very informative on this and really appreciate it. A number of the initiatives, or I'm sorry, the recommendations we've done today have had youth involved, whether it's kind of in a cursory look down the road approach or directly addressed. If we are considering to provide youth with harm reduction materials in a health hub or that sort of setting, and the goal of safe supply is to get the street supply to be to eliminate the poisoning of people from fentanyl, actually, and that's where the majority of these kids are dying, is being poisoned. I don't see where there's anything to address people under 18 in this. And having said that, it's going to create quite I don't know, the political will may not be there if it does include that. So, you know, on one hand, we're including kids, or I'm sorry, persons under the age of 18 with some of these recommendations. And in this one, it's wholly, it's not even addressed. So if there might be a comment or two on that, I'd appreciate it.
So thank you for that really important point. So absolutely 100% like that the youth need to be considered when talking about safe supply from multiple angles. So there's the angle of the people who, the children, the younger people under 18 or under 21 who are using now are at high risk of overdose, because not only are they exposed to the same street supply as older people, they have much less information. They're much newer in their use, and they'll do a lot more dangerous things. So having a supply that's safer for individuals is something that I think, and the evidence has shown, would have a pretty large impact. However, as you said, the political will to talk about giving or supplying teenagers with drugs is sometimes not often there. But also you get the flip side where people talk about if these people who are under 18 or under 21 are using drugs, then should we provide them with their first dose, like this first tested dose the first time, if they want to use the first time? And I personally land on yes. I think it's safer compared to them having to go to a dealer and having to go access the illicit supply. The money theoretically would be going to the black market versus a legalized market for that purchase. And it also keeps that person safer, as well as provides a point of contact for education with someone who's younger. However, I don't see a model that would provide it to individuals under 18 or 21 in the sense that we have those the same restrictions on alcohol as well as on cannabis. So if it was one of the more like non-medicalized models, then I think you would have to put those age restrictions, because that's the precedent that exists. But for medicalized model, if you dispense it like something like methadone or buprenorphine, I think there can be a conversation about providing a safe supply to individuals under the ages of 18 or 21. And I think this working group would be a really good place to have those conversations at the state and kind of gauge the political appetite about what would be feasible in terms of political will as well as legally. I hope that answered your question.
Yes, Adam, thank you very much.
All right, thank you. Hunter,
Hey there. Are you guys able to hear me?
yeah,
Good,
loud and
good.
clear. Thanks.
Yeah. So I'm in full agreement with what I just heard, and as someone who is a youth and also has lost people to fentanyl overdoses, just like their first time just experimenting with something, like I want to fully support what we're talking about right now, because like it really does take a lot of thought and discussion to do this right. And I know if we were to just pass a recommendation to legislators right now about youth below the age of 18 and like safe supply, it probably wouldn't go through because they wouldn't think that's very moral. But I do think that there is a way that youth could access things safely, because really at the end of the day, we can't stop people from experimenting. Um, and also, I recall a couple meetings ago, Caleb was talking about some of the stuff that has been done in other states or countries, and one of them was about there was a group that was purchasing drugs and testing them and then redistributing clean substances. So like when I think about that, I think that could be a somewhat ethical way to move forward. So I think discussions like that can be done in a work group. So I like this recommendation.
Thank you very much, Hunter. Appreciate that. Any more comments? Okay.
Could I
Michelle,
just
shall
make
we
a
vote?
quick comment on what Hunter
Yeah,
said?
absolutely. Yes, sir.
So thank you, Hunter, for what you said. I completely agree with everything that you said. That I think it's really important to like think about this carefully and how you present it, because there are models of legalizing these drugs where you could cause harm. So having a conversation about how do we do this safely, how do we do this in the best interests of the public health, keeping people safe while keeping them away from predatory practices like what was seen during the early marketing of Oxycontin. So making sure that misinformation and companies aren't allowed to share misinformation about drugs is, I think, also really important. And I just want to touch on the Dolph model that you talked about, the one where they're buying for communities and not. Um, for the one they're buying, like buying it, testing, and redistributing it to the communities, they have specifically for like political appetite not given it to people under the age of 18, which is the age of majority in Canada. So they have been very careful to only give it to existing users so far because of the political will and the whole idea among, well, we need to keep drugs away from the youth, because that's a really hard political conversation to have. But I think it's a really important conversation, as Hunter touched on from his experience, and a lot of people know from their experience. It's like our imperative as a public health to protect the most vulnerable people, and that includes people under the age of 18 who are just starting to use, and to make sure that even if they want to use drugs once or twice, that they're alive to see the rest of their lives, because there's just so much wasted years of life and opportunity, and there's just so many people who have died and people who we all know who've died, and it's heartbreaking.
Thank you, Adam. Okay, any more? I've got Adam here. Any more questions? Michael?
Yeah, thank you for bringing this forward and to think about the committee and such. I'm just looking at the language on the committee. I want to make sure that we're hearing or seeing things the same way. It says the work group should center people who use drugs with lived and living experience and who have lost loved ones. When I see that should center people who use drugs, I'm assuming we're saying we should include people, be inclusive of people who use drugs, those with lived and living experience. and who have lost loved ones. If I look at lost loved ones, is that lost loved ones from they've passed away, or they've lost, meaning they've lost contact with them because they've become disenfranchised? I would like to be inclusive of all, but I just want to make sure that we're on the same page on those things.
Well, Caleb, you had your hand up.
From what I recall last week's meeting, Lisa Dugard mentioned lost loved ones in terms of people who had lost loved ones to overdose death. In terms of centering people who use drugs, I will start the conversation, but I'd like to turn it over to the people who spoke to it more specifically, which I think included Deontay. And it isn't just including, but it's actually making that the focus of the group. That centering around drugs, what it sounds like, it's a person-centric view of the universe, like the heliocentric view of the universe. That the people who use drugs are at the center and driving the conversation, not just participating in the conversation. I don't know if other folks who were at that meeting want to say a bit more about how they view that idea of centering people who use drugs in the conversation.
Please comment. Sarah.
Yeah, sure. To say a little bit more about that, really everything that we heard in public comment at the beginning of this meeting today about the ways that people who have living experience or have lived experience have felt alienated from sharing in this venue in these groups and taking that feedback and putting it into practice. We're talking about the creation of a new work group to promote less deaths by overdose and promote health outcomes for this population. We have the opportunity to do things differently in a way that centers those voices. So, we were very intentional in language around centering versus including, and I'll let others share more about kind of what that means to them.
Thank you. Malika.
Absolutely crucial that this, as I think that was a really good metaphor, Caleb, that the heliocentric metaphor, it must be centered on people that have living experience. And also, I'm just going to reiterate a concern that I have stated multiple times when we talk about having separate discussions removed from the policy discussion, that that's creating another silo. I think that part of what we learned, what was reiterated this morning, is that these policy discussions need to change so that they are more inclusive of people with lived and living experience. And it's not that we're having separate conversations, that we're having one conversation that everybody feels welcome to participate in and valued in. So that's what I would suggest. I just get nervous when we start talking about having separate conversations.
Because in my opinion, I think that these people with lived experience, they are the conversation. They are part of these plans that we're going to have go down this, that'll be SURSAC at the end of these SURSAC conversations. And I just really just hope that as we are going about this, that we're continuing to put those voices kind of to the forefront. I think that as much as we have 5 years to go through this plan, and there's a lot that we can learn. A lot of us have been cooped up behind our computers doing the Zoom, and I think a lot of the people that of lived experience that are losing people by the day should be implemented in the conversations, not separate. What they have, the conversation that they're bringing is essential to what we're bringing here. And thank you, Sarah, for your statement. You pretty much took it home, and I appreciate that.
And I'd like to add under the who have lost loved ones. I think that Lisa meant who have lost loved ones to overdose. That was the context that I remembered her saying.
All right. Thank you, Malika. Thank you, Deontay. Michael, hopefully that got your questions answered. Adam, anything you want to leave us with here before we vote?
No, just again, thank you again for considering this. I think it's a really important conversation that we should be having. and hopefully we'll see what happens. But I think it should be an important conversation to be having, because we're just at the start of our fentanyl spike. It's going to get worse before it gets better, and we have a unique opportunity to learn from other jurisdictions on what to do and what not to do responding to this. And I think we have the opportunity to save a lot of our loved ones and our young ones, is how I would put it. So thank you again for considering this and for hearing me out.
Thank you. Okay, Michelle.
Mm-hmm. All right. All right, all those in favor of including this recommendation in the plan, please raise your hands.
Give it a second here. Okay, we have Addie Adwell, Senator Dingra, Teresa Atkinson, Caleb Banta Green, Malika Lamont, Julian Saucier, Hunter McKim, Rep Davis, Amber Daniel, Sarah Melfi Klein, Alexi Orr, Kevin Ballard, Brandy Flood, and Sherry Candelero. That's 14.
Thank you, everybody. You can put your hands down.
I still have 2 hands up.
Yeah, Teresa and Amber, I'm just lowering your hands. All right. If you are opposed to this recommendation, please raise your hand now.
See 0.
And if you would like to defer this recommendation, please raise your hand now.
See 0.
If you are abstaining from this vote, please raise your hand.
Michael Langer. Thank you.
All right. Thank you, everybody.
Okay, one more to go. Looks like we're still not at the time on the edge. Oh, there's Everett. Awesome. Awesome timing, Everett. So we'll give you a second to group here. And there you are, sir. Thank you for coming. And we are ready to hear about, I think, a recommendation 11. Yeah, initial SUD engagement and measurement. So whenever you're ready, sir.
I was hoping to have like 15 minutes to sort of read the room and see where we're all at, what's going on. And instead, I'm just going to jump on in. Hello, everybody.
Hi.
It's wonderful to be in a meeting where you're ahead of schedule, isn't it? Everyone give a round of applause to yourselves. I'm just going to talk a little bit about, I know that there's been lots of discussion about initial SUD assessments. As a rural provider, it's been difficult for me on behalf of my clients to find those specialists who can do assessments for people. And in the past, before we had several different low barrier Suboxone sites available to people in my region, folks just routinely had to wait 2 to 4 weeks to get an assessment, which seemed a little. It was hard for us to explain to them why that was the case. If someone has been using opiates for 20 years, misusing them, it just seemed like, why do we have to wait for someone to tell us they have severe OUD? So it was hard to kind of explain to the public and people, affected by substance use, why they had to wait. In the midst of waiting, then we saw folks, be told various things like, please abstain until then. Well, if they could abstain, then they don't need the detox, in 3 weeks because they would have done it. And if everyone could just will themselves to be better and not have this disease anymore, they surely would do it. We would see many, many people pulling themselves up and not having this issue anymore. But that's just not the way that these conditions work for people. So this recommendation really is to try and help get at the many areas of the state where those wait times are long. We know we can assess people clinically. We know we can assess mental health. We know that we can get information in on them in an initial assessment and then immediately get them some of the treatment and care that they need and do follow-ups for some more comprehensive assessments for people. But this is an attempt to sort of follow what's happening with OUD around the state as people are now coming in with fentanyl dependencies. The risk of their overdose and the risk of overdose death to them is much, much greater than we have seen in years past. And we really need the state to be able to pick up and respond to what's happening on the ground. This does not mean that nobody cares about SUDPs or that we don't want to see traditional systems continue the great work that they have done, but that we need some other protocols and strategies on the ground so that we can meet people where they are truly and serve them right away. So that's kind of my roundup. I'm happy to take any questions about this strategy in the document. And there's many other experts here who can also answer, of course.
Questions for Everett? Comments, concerns? Does anybody need to see the document? Hopefully you've seen it.
This is why you're all ahead of schedule.
That's all good. Thank you. Thank you for being here.
Thank you.
Okay, shall we go ahead? Okay, Senator Dingra.
I just have a question. I love this recommendation, by the way. So I'm guessing our agencies like HCA, DOH would be willing to pay for any treatment without requiring an evaluation, correct?
Well, I want to be clear, it's not evaluation. The recommendation is specific. This is Caleb, around the ability to do a diagnosis and determine medical necessity and not mandate anything that takes more than 15 minutes so that care can be initiated same day. If the client wants a full assessment for some other reason at that time or in the future, they could get that, but that it would not be mandated in order for them to be able to initiate care that same day.
Correct. I just want to make sure there are no issues with paying for that care from the state's perspective. So I don't know if HCA can answer the question.
I think that, yeah, we'll see what Michael says. I think there are. Sorry, Senator Digger. I think there are issues, and I think the point is to signal that those issues need to be fixed because it's killing people.
Yeah. Okay. Yeah. Perfect. I just wasn't sure if we were specifying. Actually saying that and saying, get treatment that is paid for, and the assessment can occur as needed, or like it shouldn't be. You shouldn't need an assessment in order to start the treatment. That there should be flexibility on like you don't. Doesn't have to be consecutive. Like you can do all those things at the same time to make sure that you can provide what the client needs at that time.
Yes.
I think we're saying the same thing. I just want to explicitly call it out that that's what we're talking about.
All right.
That's great.
Thank you.
And Michael, if you're going to speak, you still look muted.
Yeah. The direct response, Teresa, and then we'll get to your comments.
Yeah, I'm sorry, I got lost. I thought we were going to Teresa next. So you want me to speak before Teresa?
No. That's fine. I thought you had a direct comment. Go ahead, Teresa.
Yeah, my direct comment is that right now,
Thank you.
and has been since I believe the beginning of 2019, you do not need an assessment to get into treatment, but you have to have one within the first 48 hours, and the HCA is required, sorry, not the HCA, the MCOs are required to pay for the first 2 days awaiting the assessment.
All right, thank you.
Yeah.
Appreciate that. Michael, go
Yeah,
ahead.
there's a little bit more leniency with withdrawal management as well. So if I'm not reading this right, then I need to be corrected. But I think what this is asking for is for us to convene a group to look at and see if there's a way of reducing the barriers further than even that. So if that's what this is about, then I understand it. If it's saying something else to do, right? I mean, I guess Everett, maybe restate it again, because I'm reading it and it said pull a group together and look at how we can reduce it down to find a way to try to get the assessment, or at least the screening, to meet medical necessity within 15 minutes or something. So you want to maybe clarify a little bit more what your intent of the recommendation is, please?
I'm happy to do that. I see Caleb chomping at the bit, though. Caleb, okay. I think when we were, in our prior discussions, what we were trying to get at was, being able to get people onto treatment, see them same day, on demand, without requiring a longer assessment, or especially an assessment that requires an SUDP or some other special certification, because those are just not as available. And they're not only not available like within the same week, they're sometimes not available within the same month for people. So then we just don't see them, they don't come back. So we're looking for not just a working group to look at the matter. We know from the low barrier Suboxone clinics that UW has already stood up around the state that they do a really good job of getting people in right away. And so I thought that the intent of this recommendation was to be able to work with more flexibility without having to go through a specific protocol to get people into treatment. I could be wildly off target.
So you can get there through the prescribers, right? For MOUD, for example. And Teresa's brought up that it was addressed around withdrawal management and residential in terms of that window of opportunity to get folks in right away. We'd have to go back and look at outpatient, Everett. I'm not prepared to make a statement about that right now, but I guess I understand the intent of it. But if the question is, can we make this happen tomorrow? We'd have to certainly take a look at this and examine what we're not thinking about here on the fly. So I think the general direction here is what I'm seeking. I think I understand it now. So thank you.
Okay. But yeah, with all due respect, we have all been talking about this specific recommendation for several months now, and I continue to see overdose death rates in my county and region beyond what we've seen the last many years. And I hope that this doesn't go just to thinking about it more. I hope that we can all act on this. Thank you.
Okay.
Thank you, Caleb. Before we get to you here real quick, Michelle, can you see Sarah's comment in the chat? Let me help out with that. Caleb, go ahead.
Yeah, and just to clarify, this is different than the safe supply recommendation, which was, hey, there's a lot to think about. We need to think this through. We need to think through options. Let's create a work group. That's how that was structured. This is like, we need to do this. We're making a specific recommendation to the state take action to enact this. It's not about think about should we do it. It's about change any necessary rules to make it happen. That's the request. It's not think about it more. It's like, please put this into place. And I'm sure there will be rules that may need to get changed. I don't know which aspects of which plans may need to be reconsidered, but I think that this is pretty serious. It's something that's been long standing and it needs to be addressed. So that's the intent of this, Michael, to be clear. It's not about developing a work group to think about it. It's like this group has met and discussed it in great detail, back and forth a lot. We've had really good, frank conversations, and we've really adapted the recommendation as well to have the language be very precise. But it is the specific recommendation to the state saying, please put this into place as quickly as possible. Don't know all the rules, don't know all the things you're gonna have to fix, please do it.
Okay. I'm reading from the document. I just want to make sure I'm not trying to make things up here at all. It says HCA, this is what you're asking, HCA convening work group who will review current processes and workforce needs related to intake, screening, and assessment for SUD services, develop how to build something going forward. HCA will bring people together, make recommendations within 12 months. In the interim, any work that HCA can undertake to advance these goals should be done. So it's that last statement I'm hearing you speak most of, like if you could do something right now, do it. But the other three bullets talk about convening a group and working through the details and having up to years to do that. So I'm just looking at how it was written.
Yes, well,
I think that's what you're
been
voting
quite
on.
an editing process, so I definitely have not memorized it. But the intent is we need to do this ASAP.
Yeah, I understand.
All right, thank you. Any more feedback? Ever go ahead. You have something?
No, I was going to say it does say convene a work group. I think everything's always about convening a work group, and I think Caleb's right that that's a lot of where we settle on when people are unsure about things. I'm going to focus on in the interim. The last bullet point, Michael.
And that's fine. Yeah, I think and bold that. Everett, I think bold that last piece there and say if you can do something sooner, do it. Right. So I think that's your intent. So, thank you.
Okay. Any other questions, comments, concerns before we vote? All right, Michelle.
All right, just switching gears here to pull up that tally sheet. In the meantime, anyone who approves of this recommendation and would like to see it in the plan, please raise your hands.
Michael, your hand is still up.
Sweet, we finally got him to vote.
Fine, yeah, that's fine. You got another one.
Make a decision, I know.
All right. Give it just another second here. You have Kevin Ballard, Abby Adwell, Senator Dingra, Alexi Orr, Julian Saucier, Hunter McKim, Caleb Bennett Green, Sarah Milfy Klein, Malika Lamont, Brandy Flood, Sherry Colodario. Oh, excuse me. Sorry, Sherry. And Amber Daniel. Too much talking here. All right, so we have 12.
Okay, thank you so much. You can put your hands down. All right, Kevin, I'm lowering your hand. Malika, I'm lowering your hand. All right, all those opposed to this recommendation, please raise your hand now.
Right. Teresa Atkinson.
All right. And anyone who would like to defer this recommendation, please raise your hand now.
See 0.
If you would like to abstain from this vote, please raise your hand now.
Michael Langer.
All right.
All right, I believe that is the last of our presentations and voting for today. So, Michelle, we'll kick it back to you.
Yeah, just pull the agenda back up here. I believe that brings us to the wrap up and next steps a full hour earlier than we had allocated. So congratulations, everyone. Thank you so much for reviewing those recommendations, being prepared to vote. I was definitely not expecting to end early today. That's really great. I know that was a lot of material that you were sent and asked to review and provide feedback on, and so here we are. Next up, there's feedback from the second batch of recommendations that will be integrated this week for vote on next Monday, during next Monday's meeting. There was the one recommendation that was voted to be deferred from this one that can also potentially be added to the October 3rd meeting, since we do have, I think, time for that. So we'll be, the Recovery Support Services Subcommittee will be accepting feedback and questions about that recommendation until noon tomorrow. Their meeting is at 1 p.m. And I think that's what I've got for now. Michael, did you have any closing statements?
Well, thank you for the organization and getting us through in an efficient manner. That means a lot. The work groups did a good job in explaining what they were proposing. So thank you to you, Blake, all the staff, in addition to all the members who stuck with us throughout the afternoon. I would just leave folks with an opportunity that came about this weekend. We had 1,600 folks celebrating recovery in downtown Seattle this weekend. And it was pretty cool to see that many folks sharing their stories, learning from each other. This happened to be the World Conference for Oxford Homes, of which we have the most in the country. But it was really nice to see them celebrating and talking about not only their recovery and the support they get in the homes, but the health conditions they bring to the homes and the support they're getting there. Some of them talking about their work in harm reduction as outreach workers now, and just pretty contemporary conversations across. So I would leave folks with that, just hope and desire to add to our community of recovery in the state. So thank you.
I think that concludes the meeting.
All right.
Any final comments? Okay. All right. Thanks so much, everyone, for coming and being here and your work. So
Bye-bye.
see you next time.
Thank you.
Take care.